Welcome to Ventricular Rhythms. This section will be focusing on all electrical rhythms originating or having to do with what's below the AV junction. Quick reminder on the anatomy and physiology just to warm up. You of course have your four chambers, you have the atria up top and the ventricles below. Within those ventricles, the two items we're going to be most concerned about, other than the muscle itself, is going to be your bundle branches. We really won't be focusing on the bundle of His or the AV junction, those things. It's more of just the bundle branches and the ventricles themselves. We're going to be driving the rhythms that we'll talk about today. To just kind of recap or just give you a rough outline. For the basic arrhythmia folks, it's going to be pretty straightforward stuff with bundle branch, blocks, PVCs, VTAC, and VFib. Asystole and PEA. As for the advanced arrhythmia, they are going to learn about some extra items having to do with PVCs, VTAC, as well as idioventricular rhythm and ventricular standstill. Right. And on we go. Bundle branch block, quite simply put, is a situation where there is a conduction delay moving through either, so conduction delay, either the right bundle branch or the left bundle branch. And how do we define that? What exactly is a delay in conduction? How do we quantify it? Well, simply put, it is when the QRS is greater than 0.12. That's all it takes. And this is why we've been measuring it this whole time, is so that when you are going through everything and following the routine, you measure that QRS. If it's greater than 0.12, immediately you know that there's some kind of conduction delay going on with the bundle branches. As we go through the ventricular stuff, you'll learn more about that as we go. But if all things being simple, just a wide QRS is all it takes. For those who are curious, in order to truly define the difference between a right bundle branch versus a left bundle branch block, you need to have a 12 lead EKG in order to do that, because it requires all 12 leads in order to really pinpoint which side of the heart is being disrupted, whether it's the right side or the left side, that kind of thing. Just wanted to add that little fact in there. Bundle branch block rules are actually completely dependent on whatever the underlying rhythm is. Honestly, the rate, underlying, the regularity, underlying rhythm, P wave, underlying, PRI, underlying rhythm. Nothing exciting there. At the end of the day, it's when your QRS is wider than 0.12. That being said, I'm going to take a little bit of time now and focus a little bit closer on how to measure these QRSs. What a lot of it really comes down to is the J point and how to find that. So if you think about a typical clean QRS, the way it's supposed to look, you just have your isoelectric line, you get your R wave, comes down to an S, comes up, you get a nice horizontal line, and then your T wave, correct? Something nice and simple like that. In those cases, it's really easy because you've come back to the isoelectric line and there's a nice sharp point right here, and that is your J point. It's where the S wave has officially stopped and transitioned into a different part. That's all well and good, but reality will show you in time that it doesn't always work out that well. And especially when you have bundle branch block patients, what you may often see is isoelectric R wave comes down, your S wave then goes something like this, where you don't have that nice clean horizontal shelf to tell where does the S wave end and where does the T wave begin. It's just not clear. In cases like this, you essentially come down to two options. The one you're looking at right now, how would I measure this QRS? Well, I would start where I would always start, which is where my R wave begins. The end point, specifically in the one I just drew, would actually be about right here. Because at that point, I transitioned from, because we came straight down to the tip, and then it went up, and then it changed angles. And that point where it changed angles is what I'm looking at. That's where my J point would be. And so because of that, I would measure my QRS from here to here. Not the isoelectric line or anything like that. It would actually be this specific point is what I would use as my marker. One other quick example is if I don't have something quite that clean, and I'll draw it up here in the corner. Try this. If it does something along that line, where I really don't have much in the way of change of angle, it's just one smooth slope across there, what we would do is I would actually use the tip of the S wave as my end point for the QRS, because this whole section here, I don't know what part is S wave and what part is T wave. I can't tell. So for this one, you use the tip of the S wave to measure off of to get your QRS measurement. So from here to here. All right, we'll get some more practice in as we go. As always, we'll begin with numbering everything off. And there's our end right there. Okay, so we have a rate of 8 times 10 gives us about 80. We are regular with no ectopics and no pattern. Because we are regular, we can measure, and let's just do between 2 and 3 because that's fairly convenient. That comes out to right about 19. And that is 79. So we have a normal rate. If we take a look at our P waves, we can see that those are all upright and uniform. And in case you're having trouble seeing them, these are the P waves through here. So we are upright, uniform. They're at a regular rate. You could measure those out if you wanted to, but trust me, they are. And I have 1 P for every QRS, which is what I like to see. If we measure them out, this fourth beat is actually really convenient because it falls on a solid line. And that is 4 small boxes. And that is normal as well. On the QRS, it is uniform. We have an S prime pattern. Sorry, let me redo that. We have our S prime. Sorry. If we measure this out, we'll go ahead and use beat 4 again. We'll start at the same point the PRI ended. And now, this one, fortunately, the J point is quite easy to find because you have a clean ST segment, and it's right here. So we bring that down, and across here, that's 1, 2, 3.5, which is what we want to see. So 3.5, 0.14 seconds, and it is wide. And if you take just a moment to look at it, you could tell that before we even measured it, correct? It doesn't have that classic QRS shape. In fact, it's jagged at the bottom. Those are some hallmarks of having a wide end QRS, that a bundle branch block may be present. At the end of the day, we're just going to call it sinus rhythm with bundle branch block, because everything is perfectly normal except for the wide bundle branch, or the wide QRS, which is the definition of a bundle branch block. Why is bundle branch block important? Simply put, it's not natural. It's not part of the native heart function. You acquire it as time goes on. So if it's present, that represents cardiac change in some way, shape, or form. That's part one. Knowing that leads into the next part of asking the question, is it new onset or is it a baseline problem, acute versus chronic? If it's acute, that means it's happening right now. So if you started your shift without it, and then later in the shift that patient has it, that's a sign that something specifically happened. Whereas if it's their baseline, that's extremely helpful too, because if you know it exists, that will help prevent you from making errors later. That wide QRS can sometimes look like a different rhythm, particularly if the patient's heart rhythm starts going really fast or really slow, things like that. So that's really the big benefits there. That's why a lot of times physicians or other care providers will ask for a previous EKG so that they can compare what did they look like before and after. Clinically speaking, they're asymptomatic. A bundle branch block by itself doesn't necessarily mean any major problems for the patient. Now, as it progresses, in particularly a chronic fashion, that may lead to other problems as time goes on, or worsen existing cardiac problems that they already had beforehand, which then brings us to the part of what causes it. Well, ultimately, it's ischemic in nature because you have damage to your bundle branches. How did you get that damage? Well, usually ischemic is the cause. How did that happen? Well, coronary artery disease, poor perfusion to that part of the heart. And if you think about it, the bundle branches are buried really deep inside the heart. Blood flow goes from the outside to the inside of the heart, and that makes them pretty easy to injure sometimes. Other possibilities include cardiomyopathy, where you have a heart that is stretched out or is really thick, and that can be the reason why they're acting up or not functioning as well as they should, and some valvular disease can cause that as well. Which conditions are common in patients with a bundle branch block? Well, you can go back to the slide and reference it, but if you just kind of walk through these, cardiomyopathy, that's where you have stretch or thickening of the heart wall, and of course that's going to make it difficult for that signal to travel and function properly. So cardiomyopathy is definitely one of them. Coronary artery disease, CAD, definitely can be a cause, because poor blood circulation and blood flow, things like that, can lead to a little bit of ischemia, which of course can lead to death of tissues. So coronary artery disease is definitely one of them. And valvular disease, definitely. If you're dealing with regurgitation or stenosis and things of that nature, that can change the shape of the heart. Sorry, I get my delta a little bit better. And also make the heart function differently, and that can lead to bundle branch block as well. Or long QT syndrome. This is not on the list. Long QT syndrome is a whole nother thing that has to do with conduction and not necessarily what would cause a bundle branch block. So out of these, it's cardiomyopathy, CAD, and valvular disease. Those are what are more likely to cause your bundle branch blocks. Even though ACLS doesn't necessarily focus on PVCs, we still can't talk about heart rhythms without talking about PVCs, how to identify them, etc. This is also going to fit in just like the other rhythms we've talked about earlier, where this is a single ectopic focused beat, and once we recognize how this works, that'll help us learn the other types of arrhythmias that can occur in the ventricles. In this case, you've got just one single ectopic beat. It doesn't have to be in this location. It literally can be anywhere within the ventricles that it can occur, front side, back side, anywhere. And that's a lot of real estate, which is why PVCs can look so different, and we'll discuss that as we go forward as well. Ultimately, it's firing prematurely, and that's what initiates that individual complex. So it's a singular location causing a singular event. It's, quite simply put, early, and more importantly, it is disorganized. And what I mean by that is it happens outside the normal conduction system, and the impulse is conducted cell to cell, which, as we know, makes it a slower system of conducting that impulse across the ventricles, and that causes us to have a wide QRS and inverted, I shouldn't say inverted, I should say inverse T waves. And as we go forward, you'll understand what I mean by that. But those are the two big criteria for a PVC. More simply put, wide and bizarre. There we go. So let's walk through a few of these and help you get a better idea of what's going on. Premature ventricular complex rules. The rate really depends on the underlying rhythm and the frequency of the PVCs, because this will disrupt the underlying rhythm, because the ventricles are big, and so the electricity that they put off when they depolarize is enough to throw the rest of the heart kind of out of step. So invariably we'll have an irregular type rhythm with this ectopic beat, so be prepared for that for sure. It is very, very possible you may see a pattern with that, and we'll discuss a few of those items. There's no P waves with these, it's just QRS, that's all there is. Because there's no P wave, you can't measure PRI with the PVCs themselves. Wide and bizarre, those are the two big catchphrases, or the one catchphrase I think you should keep with you as you're looking at these things and identifying them. An important idea to go with that QRS is these two items. It's going to be at or larger than 0.12 seconds, and your T wave is going to be in the opposite direction from the R wave. A quick example of that is something along this line where you've got up, and then it goes something like this, potentially. Or you've got one that goes down, goes up real high like this. Those are what I mean by having the inverse T waves, is that your T is down here, but your QRS is up here. Whereas in a normal beat, you'd expect the QRS and T wave to where they're both on the top side. Start out the same way we always do. Beat number 4 is definitely ectopic, isn't it? And there's an 8 way over here, and that's a full 6-second strip. So we'll take 8 times 10, gives us 80. We are irregular. We have 1 ectopic. And there's no pattern to go with that. And since it's a single ectopic, we can't do much in terms of the rate. It's irregular, so just 8 times 10, that's good enough. Let's take a look at our native P waves. And those are upright and uniform. They are regular. I've got 1 P for every QRS. That's pretty much all there is to that. As for my ectopic, if I look really close in this zone here, I have no P waves, nothing that looks like it even resembles one. And that's good to know. For the PRI, if we do a quick measurement, beat number 3 is pretty convenient because that lands almost exactly on a solid line. It's about 4. So 0.16 normal, and that's for the native. And for the ectopic, of course we have no P, which means no PRI. QRS, for the native QRS are uniform. They have QRS pattern. Looks like they are about 2 small boxes across. And so that is normal. And we'll just take a look at our ectopic then. What do we see? Well, we'll start our measurement right here. And we'll end it as close as we can get to the J point, or ST line. And this one, fortunately, has the deep Q wave, which then transitions into an S and comes back up, and there is actually an ST segment here. So this is the true end of it. And if we measure that out, 1, 2, 3.5. So our ectopic has QS as the pattern, 3.5 small boxes times 0.04. And that is definitely wide because it's greater than 0.12. If we look at the overall layout of this, we can tell that the premature beat is just that. The ectopic beat is premature. It happens earlier than I would normally anticipate to see it. So I have a premature beat that has a wide QRS. It is ugly. It's wide, it's bizarre. The QRS complex points downward and the T wave is pointing upward, so those are opposite of one another. And that's exactly what we need to say that this is sinus rhythm, because our heart rate's 80. Sinus rhythm with 1 PVC. These next 2 slides are going to be a little bit tedious, but I'm doing this to give you a lot of opportunity to learn how to properly measure the width of a QRS, particularly when they have a unique layout. And so your big rules, of course, you're looking for a QRS that is wider than 0.12, and your T wave is inverse or opposite. So we'll just start and work our way across with these. This here has the RS pattern. On that, I'm going to say that my P wave my QRS starts on this solid line, because if you look about right there, where my QRS would end, honestly, the best place I could put the J point is going to be right here, because you do see a notable shift in the way it flows. And for that, actually, wait, I will take that back. I'm going to put it right about here. That's 4 small boxes. Of course, that would multiply out to 0.16. That there is going to be your J point. Next one over is really just an R wave, because the S wave just slopes down. It doesn't really exist much, honestly. And so for this one, we will measure right from about right here to about right there. And that one comes out to right at 3, maybe 3.5, which gives us 0.14. So pretty snug. I'm going to go ahead and say, though, that the J point is right at that sharp point where the R wave ends, and it essentially transitions into an upside down T wave. The next one below is this one here, and that is essentially a QS pattern. Because of the way it lays out, it crosses over the isoelectric line, and that's where I'm going to officially call it off and say the S wave has ended. Anything beyond that is just some sort of T wave. So for that, we would start right just on this side of the line, barely, and I would end it right about here, calling this my J point. So because of that, this one's right at 3, which comes out to 0.12. But again, if you look at how that is compared to the other beats, it is wide. It's got a massive T wave that's pointing completely the opposite direction of the QRS. And that's why I would leave that right where that's at. Or I would go ahead and say that that was a PVC because of it. Our next one here is going to be RS. This one's a little bit easier to do. The QRS starts about right here, and that S wave changes right at this point. And so if we connect those two together, that gives us 4 boxes, which is 0.16. So if you look just across all of these, you can see how the T wave and the QRS are opposite of each other, but that it is really challenging sometimes to decide where that J point officially ends. I could easily see having a discussion with someone on this one here, that this might technically be the J point right about there instead. Ultimately, we know that that's a PVC. So here's a couple more examples. So continuing on naming and measuring PVCs, we have this one, which is R prime S. So that's actually a little bit more complicated than what we've seen. The R wave starts right about there. And in this case, it comes down to a sharp S point, but because the transition goes up and then changes angle like it does, this right here is where my J point is going to be at, this location here. And so if we translate all of that down, comes out to right at about 4 small boxes, which gives us a 0.16. And again, you've got your larger QRS. Most of it is downward as an S, which is why this T wave here is then inverse of where the majority of that electrical flow is at. If we look at our next one, we have a QS pattern, and within that, this one here is, because of the way it's shaped, the most consistent location in which to say that the QRS ends is actually at the tip of the S wave, where the QRS starts right about here, but honestly I can't tell where along this pathway the S wave ends and the QRS and the T wave begins. So if we just go for right here, that gives us 0.08 for my measurement, but just looking at it, how it's shaped, the way it's behaving, we know that it's a PVC. Our next one with E, that is a QSS prime that we're looking at. And this one's far easier to measure, right? Because this one definitely starts just about there, and this one ends here. And so because of that, using that same idea of using the tip of the S wave as my J point, gives me a measurement of 4.16. I'm going to say S equals J point. I'll write that here as well. Last one. This is R prime, and way easier to do because nice clear end here. The R wave comes down and then just kind of curves off gently. That's enough to say that's when the QRS officially ends, 0.16. And that's the best way that I can help you learn how to determine when a QRS ends and when a QRS starts and things like that to help do your measurements with. An easy concept to master is the idea of unifocal versus multifocal PVCs. And it's really straightforward. In front of you, you see two different strips. And quite quickly, you'll notice that the first strip, strip number 1, has PVCs that all face the same direction, whereas strip number 2 has PVCs that actually point different directions. And we quite simply say this. Just draw these out real quick. You can see it, and so the official definitions are as follows. A unifocal PVC means that they originate within the same place of the ventricle, and they have an identical morphology. So if you take that concept and apply it to multifocal, it means that they have a different morphology. Different morphology and different origin. And why is that important? Why am I bothering to tell you? Well, if you have unifocal, that means one spot is a consistent problem. If you have multifocal, that means you've got 2 or more locations within the ventricles that are causing trouble, and that's something you want to be really aware of, because that means the patient may actually be in worse shape because there's more than one injured area. And as we go on, you'll see how these patterns can come together. PVCs, couplet or a pair versus a run of PVCs. What does that mean? Well, I'm going to try and show you over the next few slides. But we'll start out the same way we always do. And this is longer than 6 seconds. But in the first 6, we have 8 beats. So we have a normal rate there. The overall strip is irregular. We have beats number 9 and 10 are ectopic. There's no real pattern across the strip, but that is a pair because they happen one right after the other. You're just looking at it, you would call it a pair, correct? Well, we'll dig through and we'll figure out what we can get. As for the P waves with the native, they are upright, uniform, they are regular. The PRI, as I measure it, It's about 3. Oh, and I have 1p for every QRS. As for the ectopic beats, I don't have anything that looks even close to a P wave. The native, I measure that out to be 3 times 0.04 equals 0.12. And so that is normal. Ectopic has none. QRS for the native is uniform, has QRS pattern, and if we measure that out, that's 1, 2.5, 2.5 times 0.04 equals 0.10. And so that's normal. So our native QRS is, for all intents and purposes, perfectly fine. So we'll take a look at the ectopic one. Well, we mentioned that they were paired, so we have that already. They are wide, and they look bizarre. Correct? That alone is enough for you just eyeball it and probably say that it's a premature ventricular contraction, but we still have to do our measurements. We have to be thorough. And so we'll take a look at beat number 9 and see that there is a start point about there for the QRS. Where's my end point? Well, in this case, we're going to go ahead and use where the R wave essentially ends and starts sloping off into a T wave, which is going to be about right here, this point. And that comes out to about 3.5 boxes. And that's what makes this difficult is because, or well, it makes it a little easier to measure in this case through lead number 2 because I have a clear start and a clear end. Now my second beat, it's a lot more difficult to tell, when does that T wave end and the QRS begin, things of that nature. Honestly, I would probably cheat and use the lead V2 if I really needed to measure it. But because they're identical, they look so similar, the need to measure the second one isn't really there. And at that point, I can just use my 3.5. It gives us 0.14, which we mentioned already was wide. So the only other thing we have to add in is how the T wave looks, and the T wave is inverse. And if we were going to name those, I would probably name them tall R and a tall S for the sizing on that. So we've gone through all this. What do we officially call it? What don't we call it? The most important thing I want you to learn is that a pair is not the same as a run of PVCs. You technically have to have 3 or more PVCs in a row to have a run. And even then, that's technically VTAC, and that's what we'll talk about next. As for this strip here, quite simply, they just have sinus rhythm with paired PVCs. A bit more challenging, but to follow up on the discussion we just had about paired PVCs. What is a run of PVCs? Well, this is what a run of PVCs looks like. So let's go through and figure out exactly how to quantify it. And we'll do everything the same way as always. This is a simple 6-second strip We'll start by doing native ectopic. So the native part of it, grand total, it's irregular all the way across the strip. Tally them up, 9 times 10. 90 is the overall rate for the strip. That being said, we really do need to look at that ectopic section as well and figure out what's going on. If we take just a moment to look at it rate-wise, we can see that those are pretty well even, those ectopic beats through the center. And we'll just go ahead and mark them out to measure them and say from here to about here is 5, 10, 12 and a half. And so if we take 1500 divided by 12.5, that gives us a rate right in the 120s. And so that's good to know that we have a tachycardic rate for those big, wide, ugly looking beats in the middle. We should still do due diligence and try and figure out all the rest though. We'll say that we are irregular. We have what I would guess to be sinus rhythm just by eyeballing it, or at least whatever the underlying rhythm is, into ectopy. And we'll say that there's 5 total beats of ectopy as well. I don't really have a pattern overall other than it happened. So if we look at our P waves, you can see that those are upright, uniform. I have 1 P for every QRS. And so the question of whether they're regular or not comes up. How do we prove that the P waves are happening regularly? Well, because of that ectopic mess in the middle, it really throws things off, but we can compare them a bit. So if I measure from start of 1P to the start of the next, that's about 19. And if I go over here and I do the same, and I check out these two, I will see that those also come in right at about 19 as well. So they actually maintain cadence pretty well. We've done that. Let's take a look at our ectopics. And do they have any P waves at all? Is there anything in that location where I would expect to see it? And there is definitely not. So we have no P's. For the native, what do I have for a PRI? We'll just measure this beat number 2, say that it starts pretty much there and ends there. 1, 2, 3, 4. And so 4 times 0.04, 0.16. And the ectopic does not have a P wave, so we have no PRI. As for the QRS, the native QRS is uniform. We have the small q, large R, S pattern, and that measures width-wise to be right at about 2, yeah, we'll call it 2.5. 2.5 small boxes times 0.04 gives us 0.10, which is again normal, so that's good to know. Make mention of that. So we have normal QRS, normal P wave, so that supports the idea that we definitely have sinus rhythm as our baseline. But now we have to figure out with what? Well, sinus rhythm with, let's go ahead and finish our analysis here. The ectopics, they are uniform, which means that they are unifocal in nature. They have the QS pattern. The T wave is inverse, and they are wide and bizarre. Last thing we need to do is measure them, and if we take beat number 5, it'll be pretty easy. And this actually has a nice little shoulder for a J point, so that makes that easier to measure. That comes out to 3.5 times 0.04 gives us 0.14, which is not unexpected. So if we put all of this together, we have all the information that we need to say that that is indeed a premature ventricular contraction. It's more than a pair, because it's more than 2. It's actually 5 total. So the many ways we can say this is sinus rhythm with 5 beat run of PVCs. And that's exactly what it is. Important things about this is we always need to say how many. So we always need to make mention of number of PVCs that are present. The other part that you can, and I think should mention, is that any run of PVCs, so 3 beats or more in a row, constitutes VTAC. And so in parentheses, if you write VT, that kind of covers you there, that it's a 5-beat run of PVCs, technically VTAC. You can further subdivide this and say things like non-sustained. And that's because it was less than 30 seconds worth of VTAC, and that's why it's non-sustained. We'll dig into some more of that a little bit later. But again, always count, always relay the number of PVCs whenever you have a run of them. There's a lot to unpack on this slide, so I'll try and move through it as quickly as I can by numbering. But the idea is certain patterns can develop with PVCs. In fact, it can happen with any premature beat. It can do PACs, and PJCs can do this as well. We're just going to focus on PVCs because they're so much easier to see. I'm just going to go ahead and number off all these strips first while you look at these, and you'll notice the wording, the bigeminy, trigeminy, quadrigeminy. So as you look at that, I'm going to guess you can figure out why we use the words that we do. And this also illustrates the importance of using very specific words when communicating, because this really is a new language that you're learning. And this new language is how to take these electric squiggles on a piece of paper, turn them into words so that you and I can communicate without me having to have the paper in front of me to show you what's going on. So in our very first strip in the top right corner, this is bigeminy. Specifically, now all these are 6-second strips, and since there's 12 beats across here, this is sinus tach with bigeminy PVCs. And ultimately, you got to use a little bit of Latin, but the bi means 2. And Gemini kind of means twins, if you want to think of it that way. At least that's how I've always kept it straight in my head. The Gemini represents the twins, the siblings, and so for bigeminy, that's 2. So every other beat, and if you look at this pairing, you can see that you've got a normal ventricular, and then you've got a normal and a ventricular, etc. The next one down is going to be your trigeminy, which equals 3. And so in trigeminy, as we look across, there's 12 beats total, so we have sinus tach with trigeminy PVCs. Last but not least, down here at the bottom, we've got quadrigeminy, and there's 11 beats, so it is sinus tach with quadrigeminy PVCs. The parts that make this interesting and why I take the little extra time to explain it is, one, saying it's really cool just that you're using the right words, but also quad equals 4, by the way, where every fourth beat is a PVC. An important concept to learn is that because premature ventricular contractions are early and they come through the ventricles in a disorganized fashion, that a PVC doesn't really always make a pulse. Because of that, it's early, so the heart doesn't fill right, it's disorganized, it's like squeezing the toothpaste from the bottom. And so we have it's early and disorganized. And for that reason, the heart rate, which is what I have on the screen here, you count the number of electrical signals on the screen, heart rate is not going to be the same as the pulse in a lot of these cases. And so let me demonstrate. So for this rhythm here, we have a heart rate of 120, correct? Thereabouts. But because those PVCs, every other one, isn't actually moving blood, you have an actual pulse of about 60, because it's half. To help continue on that trend, if you look at the trigeminy, you have a heart rate of 120 again, but the pulse is closer to 80 because more of the beats are normal, therefore the pulse is better. In your quadrigeminy example, you've got a heart rate of 110 and a pulse of about 80 as well. If you take and dig a little deeper, that's important. So if I say sinus tach with bigeminy PVCs, you know that half of that is not going to be working properly. So you take sinus tach, which is a rate of 100, cut it in half, and get down to 50. That's not bad. But if I said sinus bradycardia with bigeminy PVCs, so sinus brady starts at 60. And so if I divide that by 2, I might actually have a pulse that's in the 30s or even worse. And that's why being able to say these words and understand what they mean improve your ability to communicate. So next time you have a patient who's having PVCs, try and see if you can check their pulse and how those two things match up with one another. Are PVCs important? The short answer is yes, and you'll notice I kind of changed things up from what I usually do, because this is a discussion that's often had, is PVCs don't matter, we tell the physician or the provider and they don't immediately order testing or whatever. Well, there's a few reasons for that. I want to talk about them real quick. First off is that they are common. In fact, they've done many studies, depends on what you look at, but they did monitoring for 24 hours on healthy people, and that's people without any cardiac problems. 80% of them had PVCs within that 24-hour period. And that's pretty impressive that a healthy person's having PVCs. Well, how can we use that to guide us? Well, think about the populations you care for. If they're being hooked up to a monitor, particularly if they're hospitalized, that could be due to coronary artery disease, that maybe there's something going on along that line, and that's what's causing those. So you really do have to pair the fact that the PVCs are occurring with what's their cardiac status look like, so your coronary arteries. Another interesting point to keep in mind is that PVCs typically don't move much blood, and so that creates a situation where when a PVC happens, there's no blood flow. But then when the next heartbeat comes, there was a little extra time, and so the heart moves more blood. And what happens is you have no blood, and then a big heartbeat, and then nothing, and then a big heartbeat. And it's that big heartbeat that is really what causes palpitations. And that's what makes people feel kind of weird. And so you don't really get symptoms unless you're having a lot of PVCs. That may cause certain symptoms. But for most folks, any kind of symptoms that you feel are secondary to the PVCs and have more to do with just the way you feel. In fact, palpitations can cause people to feel anxious. And when you feel anxious, what do? You feel stressed, which causes you to release catecholamines, which is adrenaline, which does what? If you go all the way back to what adrenaline, epinephrine, norepinephrine do, they increase your heart rate and increase irritability, which makes you more likely to have more PVCs. So ultimately, for people who are otherwise healthy in a cardiac situation and having these palpitations and feeling kind of crummy all the time, if they're really anxious, reassurance is the best thing that you can do for them to try and just help calm them down and feel better. Another fun, important thing that I really feel inspired to share with everyone is that they have done studies. In fact, there was a 1,400 participant study that they did, a study of 1,400 participants, let me rephrase that, where they were on what is considered user versus non-user amounts of caffeine, and found that it didn't affect how often they were having PVCs. So that may actually be good news for some of you that that's what's going on. Now, if you're someone who drinks a cup of coffee and you start feeling your chest pounding, then you may just be someone who shouldn't be doing that. Other things that can cause PVCs to happen is hypokalemia. That's a huge one, particularly in the hospital. You get someone's potassium corrected to greater than 4.0, and those PVCs tend to just drop right off or greatly improve. Ischemia, adding oxygen. I've seen patients do that. They take off their nasal cannula. All of a sudden they start throwing PVCs because their SATs dropped down below 88. Oxygen back on, SATs above 92, PVCs go away. Of course, a good old-fashioned infarction will do it. Cardiomyopathy, you have a stretched heart, or it's just thick. A stretched or thickened heart is way more likely to throw PVCs as well because it's not laid out in the natural fashion anymore. And of course, medications can do it too. At the end of the day, yes, PVCs are important. It's the patient and what their underlying condition is that's going to drive the way we react to the fact that they're occurring. Identify which points are used to correctly measure the QRS. And so you'll look, you've got A through E, each one lining out the different portions of the QRS. Well, we can tell that A is the start of the P wave, and so at that point we can definitely take D out because that's way too far in advance. Anything with E on it, that's the end of the T wave there, so we can take E out, and so at that point we don't do C. Which leaves us our choices between A and B. So does the QRS start at B? Absolutely. Where does your QRS end? Does it end at C or does it end at D? And the truth of the matter is it ends at C because that's the best point you can find, because that slope ends sharply and then changes direction, and that's how you know where the QRS ended. And so that's where you're at. It's from B to C. What is the width of this rhythm's QRS? And I do apologize for some of the detail on it, but you can still get this answer even without that. Remember, where does this one start? Where does this one begin? That's the first half of this question. and it doesn't start at A, so that one's definitely out. It doesn't end at E, that one's out. And does it really end at C? No, it doesn't, because that's still part of the T wave through there. So we can take C off the table. Based on that alone, we're going to be measuring from B to D, and that just pretty much takes us down to option at the end, which is from B to D, and that's 5 small boxes, which makes sense because, you know, the B starts on a solid line. Your solid lines, of course, are through here, and that point D ends on a solid line, which is 5 small boxes times 0.04 gives us 0.20, and that's what gives us a bundle branch block, in case you were curious. Which of the following statements regarding premature ventricular contractions, PVCs, is incorrect? So which of these is not true? PVCs may have a wide range of configurations, including but not limited to RS, capital Q, R, RR prime, QS. Well, that's actually very true, so we can take that one off the list. Multifocal PVCs occur when more than one location within the ventricles are irritable and creates ectopic beats. That's absolutely true. That's the definition of multifocal. C, a couplet of PVCs is technically also a run of PVCs. That is not true. A couplet is a couplet. You need 3 to be a run of PVCs. Now, which then leads us actually to D. A run of PVCs is technically also ventricular tachycardia. That is true. So out of all of these statements, C is the one that is not true. Identify which of the ectopic beat patterns is present on this strip. Are we looking at bigeminy, trigeminy, quadrigeminy, or these aren't actually ectopic beats altogether? Well, I don't know about you, but just eyeballing it, D is not correct. Those are definitely PVCs. And so we just have to figure out what's going on, and I would say something like 1, 2, 3, 1, 2, 3. Using that alone and the language that we have, it's not bigeminy, it's not quadrigeminy, it is trigeminy PVCs. Your patient started the shift with rhythm A, later alarm sound, and you see rhythm B. What action would be most appropriate? Well, first off, let's see what we're looking at. Rhythm A really isn't that exciting at all, correct? This is just good old-fashioned sinus rhythm. Now your rhythm B has what going on? Well, this section right here, correct? That's going to be a 1, 2, 3, 4, 5 beat run PVCs, also known as VTAC. So since you've established what you're up against here, what are your actions going to be? Well, it does not appear to be a false alarm, so we can take that off. Notifying the CNA of a run of VTAC is also not necessary. So at that point you have to decide, again, is this non-emergent to just let the primary nurse know, or is it more of an emergent thing where you've got to immediately contact them and escalate if you're not able to get a hold of them? Because this is a self-limited run, it just happened, the patient went back to their normal rhythm afterwards. We can definitely rule out calling an RRT, that's not necessary. So that comes down to that decision, is this emergent or non-emergent? Because your patient had a nice clean rhythm and then just had this burst, I would say that this is definitely something that's more emergent, that you're going to want to contact them immediately and go ahead and escalate if you're not able to get a hold of them. So I'm going to go for option E as being the correct answer. The telemetry tech notifies you your patient was in sinus rhythm, but is now having a lot of PVCs, like every other beat. What first action would be most appropriate? Well, you have to decide, are PVCs important right now? And what the hallmark of this is that it's an increased frequency and it's a high frequency as well. And that makes it new and unique. And if you recall, the thing that makes PVCs dangerous or really not good is that the more often they're happening, the more it can affect the patient. So with that in mind, is this non-emergent? Would you have a CNA look at them? No, I wouldn't do that. Would I just notify the attending without even looking at the patient? No, I wouldn't do that either. So now you're down to, is this emergent that you need to call an RRT and have the ICU nurse come? Well, no, because again, you need to take a look at your patient first. So now you're down to, is it just you evaluating the patient, then notifying the attending, or to just notify that attending immediately without looking at them? That's off the list as well. So it comes back to that core concept. Anytime you have rhythm changes like this, the primary nurse needs to be the one who evaluates the patient and then notify the attending or whoever needs to take a look at the patient next. Ventricular tachycardia. This is a really big one. It's one that gets everyone really excited, and so let's talk about what it is. Honestly, it's just a whole bunch of PVCs really quick in a row. The idea is this: the pacemaker comes from somewhere within the ventricle. And it doesn't matter where. It could be here, it could be over here, it could be right in the center, it could be in the front. It doesn't really matter. What's important is that when this pacemaker kicks in, this irritated site, it is rapid and repetitive. It is just firing as quickly as it possibly can. This usually winds up being outside the normal conduction system, so you get good old-fashioned cell-to-cell conduction, which gives us the wide QRS and inverse T waves that we expect to see. And as we do a couple examples, you'll understand what I mean by that. Another key concept with VTAC is that you oftentimes lose a pulse, and when you lose the pulse, you essentially have no perfusion. Or if you don't lose your pulse, it just gets really, really poor, and that causes patients to become very weak very quickly. Sitting up and walking becomes too much, and they just can't even be able to muster that. Another quick definition, I'll say it because I need to. 3 PVCs in a row equals VTAC. Now, of course, you have to have a rate greater than 100, but that's a super nerdy thing. Oftentimes, when you see VTAC, you'll know it, and that's the idea of this course, is I want to get you guys comfortable with, like, yep, that's VTAC, and then know what to do with it. At its core, ventricular tachycardia is this. It has a rate between about 150 and 200 beats per minute. It's usually very regular, but because of how fast it's moving and how big the ventricles are, it can cause some minor irregularities, but nothing major. Your P waves, you're not going to see them, and if you do, that's not the focus. No P waves, no PRI. But these are the big ones. It's going to be wide and bizarre, just like PVCs are. And in fact, all those different shapes of PVCs, that's exactly what can happen with VTAC as well. Your T wave is going to be in the opposite direction, so it's going to be inverse of your R wave. And you're going to have a nice wide QRS. It's going to be 12 or greater, more oftentimes greater. The only other thing I want to make mention of is that you usually lose your pulse because that rapid heart rate, that's fast. 250, especially when the ventricles are moving that fast, there's not enough time for it to refill with blood, which means It's like when you're bailing water out of a sinking boat. The faster you move that bucket, you're not allowing the bucket to completely fill, and so you're not moving as much fluid. The heart functions very much in the same way. I'm just going to go ahead and start off this strip by saying check the patient. In all honesty, VTAC and even VFib are the types of rhythms where you really should just be able to look at it and say VTAC's VTAC, and that's that, and then know that you need to go check on the patient, see how they feel, check for a pulse, all that stuff. Vital signs, and then start ACLS if you need to. I'm saying all that up front because that should be your immediate reaction when you see this, is do exactly what ACLS would expect you to do in these scenarios. Now, how do you actually interpret this after the fact so that you can then communicate it with whoever the care provider may be? Well, we'll do it the same way we always do. And I'm going to use this lower tip as kind of the point where I mark the tip of the S wave, as it were. Okay, we'll call that 14. All right, we're tachycardic. What a surprise. It is irregular in the fact that it changed rhythms, but of the ectopic rhythm, it is regular. It is wide. It is big, and there is no pattern. Okay, we've got that part there. What we can do, because that secondary ectopic pattern is so regular, we can get a rate on that one. So if we just measure between 9 and 10 is pretty convenient because those are sitting right there on solid lines. I'm going to call that a 10. $150, which is also nice and tacky. So most of the fast heart rate is actually made up by the ectopic rhythm. We'll do our P wave for the native. And the one that we have is upright. I have 1 P for each QRS. There's nothing much more to go off of, simply by what we're stuck with. So we'll assume that everything's okay. We can measure the PRI on that one, and I'm going to go ahead and say that that's 1, 2, 3.5. .14. All right, so we've got normal for the underlying. Do I have any P waves at all for the ectopic rhythm? And nothing that I can see. And so because of that, no P equals no QRS. So, sorry, PRI. Got ahead of myself. QRSs for the native beat. We've got upright with QRS pattern. Measured you out, I would say that's about 2 times 0.04 equals 0.08 normal. So for the one beat that I have, it matches everything I would expect for a normal sinus beat. So I'm going to have to say sinus tach, and that's difficult to do. The overall rate is tachycardic because of the ectopic rhythm. I just have one normal beat. I personally wouldn't even call that sinus tach. I would probably start it out and say sinus rhythm simply because I have a sinus beat, and that's all I know. I couldn't tell you if it was fast or slow beforehand. That's the whole point of recording it over time, is that you can go back and compare things. But I've got sinus rhythm with whatever the heck the rest of this is. So if we do ectopic, we will note that it is uniform, has the R, S, S prime layout, because you can see how it slopes up initially and goes down. Ultimately, for the rest of it, you could maybe make the argument that it is a QS pattern instead. I have inverse T waves. And to help you guys figure out what I'm talking about here, I'll go ahead and mark these and say that this is the T wave, this is the Q wave, this is S, and then you're back up to T. I might argue that this is R, S, S prime, but looking at where we're at, I'll probably just stick with the QS mark as being what's really going on. If I measure out what my PRI is, if I measure out the QRS width in these tachycardic beats, we can use beat number 6 is actually a really good one, because that Q wave starts right on a solid line and then goes down, comes up, and has a nice J point right here. And so that gives me 3.5 equals 0.14, and that is wide. So I have a fast rhythm. In fact, it's 150 beats per minute that has a wide QRS, that has inverse T waves, and uniform. We're going to call that sinus rhythm, and not going to say width, but sinus rhythm into VTach. Because I run out of strip, I can't say whether it was sustained or non-sustained. I can say, if I want to be more specific, I can say sinus rhythm with 13 plus beat run of VTach. And you can use that instead as a way to at least mark out or make mention of what you do have information-wise. At the end of the day, check the patient, check the patient, check the patient. Because all of these beats look identical, it's important to make note that they're monomorphic. That you've got a singular looking tachycardia going on, that they don't change. And we'll talk about what the opposite of that is, polymorphic, upcoming soon. Another example of VTach. I went ahead and I numbered this one out just because things are a little bit dense. This is longer than 6 seconds long, but we have 23 times 10. It gives us a rate of about 230 in that first 6 second window. And that is definitely fast. It is completely irregular. It doesn't much have a pattern other than it's a little bit small, and then it gets taller, and then it gets small again. And to say that there's an ectopic beat, I think the whole thing is nothing but ectopics. The other thing I'll make a comment about is that, yes, there are pacemaker spikes in here. I do not want you to be concerned about that at this time, but they are there. Our focus is on the VTach that's going on instead. So, P waves. I don't have any P waves that I can find. If they're there, they must be hidden and definitely aren't driving the rhythm that we see. And if we don't have P waves, we do not have a PRI, which brings us to the QRS. That's what's really going to help us figure out exactly what's going on. The QRS is most definitely not uniform. I don't even have it. I can't even say I've got the same pattern of, RS or QRS or whatever. I don't even have any T waves. If you really look at it, there's just not much of anything. It's just up and down. It's small. It's big. And that's an important thing to make note, is that it looks like it actually changes directions. If you stare at it, it almost looks like it's pointing up in the middle, and then they start pointing down in the latter half. It doesn't actually. It's just a bit of an optical illusion. And it changes amplitude or size. And that's what I just mentioned. It got tall and small. If you look at the gauge, this is a bit of a tip that you can use to help you out. Pretty much all the strips should have a gauge on the edge to tell you how it's calibrated. And so when they get taller than that gauge, or they almost hit the maximum levels of it, that's a real hint that you might be dealing with VTach. Particularly if you look down here at this one, that rhythm goes completely above and beyond it, through that middle section there. So we've got direction change, we've got amplitude, size changes, and it's wide looking, isn't it? And so we really need to measure it. It's difficult to measure the lead 2 on this one, just because they kind of just go up and down and up and down. Doesn't get you much. We can use V2 to help us out instead, and that's one of the reasons why I have this laid out here the way I do. And for this one, I would say right here, we'll do between around beat number 12, that it starts about right here. It goes up, and then it comes down, and then you'll see how it kind of bends a little bit, but about right here is where it shifts. And so I would say this space across here, which is 1, 2, 3, 4. 4 times 0.04 equals 0.16. And that's what I would say is the QRS on this guy. You can look at a few different ones of these and maybe be able to pick out something a little easier to read. Maybe that one works a little bit better. And I would say my starting point's here, which still comes out to 4 as well for my QRS width. So it's wide. We've got direction changes, amplitude changes. This is definitely not what we saw before in terms of being monomorphic and uniform. In fact, this is what we call polymorphic VTach. And that's because it is. It has multiple waveforms that it creates as it moves its way across. We come back around to the usual stuff of wondering if it's sustained or non-sustained. And that would just require a longer strip and more measurement to be done. Again, at the end of the day, what matters about this patient, it's going to be this, that you check them. We need to see if they've got that pulse. Start your ACLS. Do your compressions. Get ready to defibrillate, those kinds of things. Why is VTach important? Well, the number one reason is that it is a lethal arrhythmia, that it is one that will, in short order, wind up leading to a patient's demise. So to kind of explain that a little bit better if I can, or in a more technical way, I suppose, it would be to say this. You've got CVD, which is cardiovascular disease. So CVD, cardiovascular disease, is what can cause either an MI or these lethal arrhythmias to occur due to poor oxygenation, things of that nature. What happens is you can run into one of two things. It's either going to be, sudden cardiac arrest or death. And the way to kind of separate those out is cardiovascular disease leads to sudden cardiac arrest. And sudden cardiac arrest can present as either VFib or VTAC. And it'll be this right here. So heart disease leads to someone going into cardiac arrest, which is usually VTAC. Well, the big thing is sudden cardiac death is basically when you've had an arrest and didn't survive. And that's what makes this so tricky and so scary is I don't have the exact number, but many, if not more than half of sudden cardiac deaths were the patient's very first sudden cardiac arrest. That they had a heart attack for the first time, went into VTAC, and that's what wound up leading to their demise. That's why VTAC is so important. And what makes it really neat is that it's actually fairly correctable. If it's caught early enough, it's one of those things that if you do the right interventions, survival is a pretty fair chance. So what's your clinical picture? Well, you're going to have that sudden cardiac arrest, SCA, and initially they may just wind up being syncopal. They may just pass out right off the get-go, or they might be in VTAC for a little bit of time, a few minutes, maybe even hours, where it's able to move enough blood and keep them awake and conscious and alive so that our interventions can be more successful. And they're going to have all those great cardiac output symptoms, right? Your shortness of air, chest pain, palpitations. If they wind up doing the VTAC or VFib, though, you could have death within a matter of minutes. Ultimately, the treatments that we're going to do for these folks, specifically in VTAC, but anything along this line, it's going to be, ACLS and BLS type things, which is you're going to look for a pulse. If it's there, you'll do the tachycardia algorithm in ACLS. If it's negative, you're gonna just start compressions. And at that point, you're gonna get your either AED or your defibrillator. And go about your business that way. But compressions is king. That's what's going to really make a difference if someone presents with VTAC. Triggers, what causes it? We talked about this already. Cardiovascular, ischemia, usually from an MI, or potentially structural issues such as cardiomyopathy or heart failure, where the structure and function of your heart has gotten so poor that winds up being one of the triggers for a sudden cardiac arrest. Your patient started the shift with rhythm A. Later, the alarms sound and you see rhythm B. What action would be most appropriate? So your patient early in the shift had this 5-beat run of PVCs, right? Technically VTAC. And assuming you notified the nurse and they've already worked them up and whatever. But if later on in the shift you're now seeing something that's along this line, which is, for all intents and purposes, a continuous run of VTAC, how emergent do you consider that to be? Well, it's not a false alarm. You wouldn't have a CNA go look at this patient. This is something that the primary nurse definitely needs to get in there. That being said, we won't say that this is non-emergent, but you have to decide, is this something that is worth calling an RRT, having the ICU nurses know first, and then calling that primary nurse, or do you just have the primary nurse handle it? Well, for me, I really do believe that this is that high-end emergency that you need to call the RRT, have the ICU nurses notified first, And then, of course, contacting the primary nurse as well about what's going on. When providing care to patients with the following rhythm, which of the following are priorities? So just looking at this without even figuring out what it is exactly, you can tell that it's tachycardic. And so whenever a patient has a rhythm that's going this fast, which you can go through and figure out, you're running the risk of having a decreased cardiac output. And that's what's going to drive your cares. So you get in the room, what do you do for that patient? Whether this is VTAC, it could be SVT, you need to visualize the patient. Absolutely. You have to go in the room. You need to check for a pulse, one of the first things. You're going to collect vital signs if you can. If there's no pulse, initiate CPR if necessary. You do want to try and confirm if they're DNR, DNI status. That way we don't go down the wrong pathway. Are you going to ambulate them to the restroom with a rhythm like this? No, absolutely not. So we can cross that off. You're going to check level of consciousness, and that's part of your visualization of the patient, because if they have a pulse, hopefully they'll still be conscious. Are you going to move them from the floor to the bed immediately? No, you're not going to. You're going to, if they've had a syncopal event, they're on the floor, just make the scene safe, get the job done there, then worry about moving them when there's enough assistance available to do something like that. So just like before, ambulation, moving the patient, that's not the priorities. Ventricular fibrillation. What's the mechanism? What's going on? In this scenario, we have multiple foci that are causing the troubles. And it is just pure chaos. And if you look at these, honestly, what's really going on is each one of these is kind of spinning its own direction and sending out ripples that just overlap with one another. It's like rain in a pond or rain in a puddle. Each raindrop sends ripples out in its own direction and just makes everything a mess. And for these folks, that just makes this terrible fibrillation, these F waves. It doesn't look like much at all. You don't get VFib unless you have some kind of underlying disease. Essentially, always something's already going on with your heart to make it weak and vulnerable to put it in this situation. There is absolutely no pulse with VFib, and that's that. Because of just how weird everything looks, that it's depolarizing and repolarizing all over the heart, every direction. There's no way that it can move blood at all. The only other thing I would say for this is it needs a trigger. That you've already got this vulnerable heart that you just give it one little push and it goes over the edge. So what are the rules for VFib? Well, there really aren't any. It's just total chaos. There's no waves. There's nothing to measure. It's just a mess. The only really finer points to discuss on VFib is the fact that it kind of has three phases. So if you look at the start, there's kind of a middle, and then there's an end. And this is over time. At the very start, it has a lot more energy. There's still calories and everything in the heart, so that your mess looks pretty big. And then you get into this middle phase, and it looks a lot less than it did before. And then in your final phase, it just flattens out completely. And the way we differentiate these is that we say coarse VFib, fine VFib, asystole. That is the true progression of VFib, is that it happens, it's coarse, and then it gets a little bit flatter, and then it completely flattens out. This can take a matter of minutes. It does not take long at all because there's no blood moving. So essentially your heart has stopped, and how long can your body go without blood flow? That's the logic behind all of this. If you ever happen to see this come across your screen while you're at work or at the bedside or whatever you're doing, you need to go evaluate this patient immediately. You're looking for the pulse. You're looking for vital signs. If there's no pulse, start compressions. And defibrillate. Now, it could just be artifact. That's entirely possible, but you cannot ignore this. You need to be at the bedside as quickly as possible. I take the extra time to point this out now because it's really not that hard to interpret. In terms of a rate, great question. It's just squiggles across the screen. There's not even really anything to measure between. I mean, I could attempt to say, maybe from this point here to this point here, and that's about 6 boxes. That gives me about 250-ish for a rate, which fast, and I could guess that, but that's not what the rate isn't what is as important as the fact that it is very irregular and that there's no pattern to it whatsoever other than it's just messy. And the whole thing is ectopic, so there's not really much else you can say about that. There are no P waves. In fact, it just looks like a mess of P waves, and it's not. There's no PRI because there's no P waves, which brings us back around to the QRSs. They are not uniform. They change amplitude. They almost seem to change direction a little bit too, but that's a lot of the width of them. But they do change speed. They do seem a little bit wider here than they do here. The only other things that we could really say about that is that the amplitude is low, particularly compared to VTAC. So I've got your gauge right here, and you'll notice every single beat across here fits within that range, and that's important to know. I really can't measure the width of the QRS. I can just tell that it's wide and I don't like it. And this is just that pure chaos. And that is why we call it ventricular fibrillation. If we're going to subdivide this one, we can call it coarse, because it does have a fair amount of size to it, which is all relative. Once you see what fine VFib looks like, you'll be able to compare it side by side. Again, this is early, which means coarse VFib has a better chance of success, theoretically, if you're able to get them out of this rhythm and back into a normal one. Okay, you ever see this come across your screen? Again, you need to check the patient immediately. You're looking for a pulse, and if this is truly VFib, there won't be one, and so you're going to start compressions. And you're going to try and defibrillate as soon as possible. As soon as possible. ASAP. All right. That being said, we'll just go ahead and interpret this like we did with the previous one. And I'm actually going to bounce back real quick so you can see the size difference of how much taller this is compared to this one that we're doing now. Question mark, I could probably guess that it's about 6 boxes, so 250-ish, so it's fast. It is irregular. There's no pattern, and it is just all ectopy. Now, if they have, keep in mind that this could just be artifact. But you have to check the patient to make sure it's not artifact. You cannot risk it being legitimately VTAC or VFib instead of artifact. I don't really have P waves. I don't have any PRI, which then leaves us to the QRS, where they're not uniform. They change amplitude. They are small, and again, that smallness is, if you look how big the gauge is for how tall it should be or could be, and the fact that they're just really small, kind of flowing within there. There's really no, I do want to say this, there is no directionality that, it's hard to say, obviously this part's pointing up and this part's pointing down, but where's the start, where's the finish? It's all really just a jumble for sure. So what we will call this one is fine V fib. And again, the hallmark is the chaos of what that is. It's just squiggles. So this kind of puts us in that middle phase. Courses, early VFib, you're likely to have a better chance of defibrillating them and successfully helping them recover. Whereas fine VFib is that next step down, so there's less energy in the heart, which is going to make it harder for them to be successful. The next phase after this is then asystole, where the heart's completely out of energy, and it's very, very difficult to help someone survive that. Write a couple words in here while you're reading the screen. All right, so what are we up against here? Well, why is VFib important? The biggest part of this is this. When a patient goes into VFib, ventricular fibrillation, they completely lose their pulse. They have a total hemodynamic collapse. They have no blood pressure, no heart rate. And clinically speaking, they're dead because there's no blood flow in the truest sense. How is this significant? Well, it's lethal. It's a lethal rhythm. How does it happen? What did this all come about from? Well, they almost always have underlying cardiovascular disease because it requires a heart that is already weakened, that one more additional insult is enough to push it over the edge and go into VFib. So cardiovascular disease, a triggering event, such as ischemia or something else, causes the sudden cardiac arrest, where the patient winds up having full hemodynamic collapse. They, drop in BP, no pulse, stop breathing, respiratory rate, stop breathing. And that's why they need absolute and total support to survive. Without intervening during the sudden cardiac arrest, you're pretty much guaranteed to have sudden cardiac death instead because they did not recover. BLS and ACLS are huge. Compressions are what's going to make the difference, because when this happens, it's minutes that they have to survive. And so by doing compressions, that buys you time, so we can do our other interventions to help them hopefully have a good outcome. Other triggers other than the cardiovascular disease and ischemia is structural stuff, which is heart failure and cardiomyopathy, and anything else that causes structural issues with the heart that makes it more vulnerable. The last little tidbit I want to add in with this has to do with the syncope, and it's the idea that your sudden cardiac event or sudden cardiac arrest happens. You have total drop in your hemodynamic system, blood pressure and everything stop, and you wind up having a case of syncope, and that is where you literally drop dead because all at once your heart just stops. You pass out, you hit the floor, and they say that phrase like they were dead before they hit the ground. This is what causes that to happen because VFib is so lethal to people. And by the time anyone can intervene, it's been too late. The telemetry tech notifies you that your patient appears to be in ventricular fibrillation. What first action would be most appropriate? Well, if your patient's in VFib, we know that that's one of the lethal arrhythmias. So is this non-emergent? Absolutely not. You wouldn't delegate the CNA to go look at this patient. Do you call your attending right away without even looking at the patient? No, we wouldn't do that. Now, while this is emergent, you wouldn't notify the attending without looking at the patient first, so we can take that one off. So now you're down to the primary nurse being the one who evaluates the patient and starting ACLS or BLS if there's no pulse, or do you call the RRT and potentially delay care? Well, I would say don't call the RRT until you've laid eyes on the patient. Your most appropriate first action is going to be you as a primary nurse getting in there, evaluating the patient, and starting that BLS, because minutes matter if the patient truly is in VFib. Now, for the most challenging rhythm you'll learn this entire course. All right, that's not true. In fact, asystole is one of the most straightforward ones you can possibly come across. The idea is that the heart has lost all of its electrical activity. There is just nothing being produced by the cells of the heart. If there is anything being made, it is inconsequential. Another way to phrase it is there is no native pacemaker to initiate the pulse, and the reason for it is essentially always because there is no oxygen being pumped to the cells or brought to the cells of the heart to help keep them going. And without oxygen, there is no energy to repolarize. No energy, you can't repolarize, and therefore you can't make an additional impulse. This has a grave prognosis. It's one of the poorest possible outcomes you could think of, or that we've been able to find in terms of cardiac arrest and things of that nature. Essentially, the heart is dead. other things. Nothing coming from the heart. And so a bit of the explanation I want to give just to make sure I don't miss anything. Things that we can do when we try and take care of these types of patients, it's compressions. And then the ambu bag, in that they need circulation and oxygenation provided to them in order to survive. Without that, they have nothing. The rules for asystole are as straightforward as you can guess. This is asystole. It's just a straight line. There's no electrical flow going any direction through the heart, which is why there's no rate, no regularity, no waves, no PRI, no QRS. It's just nothing. And that's why it's such a grave prognosis, is there's just nothing there. I hope you say it before I can finish writing it. If you see this on the screen, you need to check the patient. Even if it's just, leads off. Can you risk the patient not having leads on and having something like this occur in a matter of a few minutes? So we've talked about how VFib can progress in a very short period of time into something like this, asystole. So you must make certain. That the patient is okay. In terms of interpretation, there's no rate. It is very regular. There is no pattern. There's definitely no ectopy. No P waves, no PRI, and no QRS. There's no pulse. And what do you do to help take care of these patients? It's compressions. You're going to be bagging them, providing oxygen, and your maybe epinephrine pushes to help them. And that is all you can do to try and help these folks survive. Why is asystole important? Well, the patient's dead, so we'll start with that. That's why asystole is important. Either that may be the outcome you were hoping for if it was a withdrawal of cares, comfort cares patient, or it may be completely unexpected, in which case, we need to intervene accordingly to try and correct for it. It's the very, very poor prognosis, and the only way I can explain this well is like if you think about a battery. Just hear me out. So you've got a battery that's just got a little bit of charge left in it, and it's in your phone or a flashlight or a camera, whatever. If there's a little charge left in it, you can turn it back on, right? Like power off the phone, wait a little minute. Okay, I'm going to turn it on just long enough to do one thing and then turn it back off. And it works. And that's what like VFib and VTAC are. When it comes to asystole, the battery is completely spent. There's nothing left in it whatsoever. And that means that because it's been completely drained, if you try and turn that device back on, or in this case you try and get the heart running again, it doesn't have enough charge. It won't even turn on at all. Maybe if you're lucky it might, but that's very, very rare that occurs. And so in that battery analogy, asystole is a completely drained battery that has very little hope of successfully restarting. Typically, the patient has been in cardiac arrest for some time. and that's why it has degraded to the point where it's at. All you can do is compressions. Bag them. And then maybe try some epinephrine to see if that will help. Triggers, lots of things can cause asystole, and it's pretty much all cardiovascular in nature. So hypokalemia, ischemia, infarction, medications, cardiomyopathy, all those things. Pulseless electrical activity, otherwise known as PEA. So what is it? The technical definition is as follows: that any organized rhythm without a palpable pulse or measurable blood pressure. And that's essentially it. So if you look at the screen, this looks like sinus tach, right? You know, you've got your P, Q, R, S, all that looks good. It's ticking right along, but you have no palpable pulse. So that you look on the screen, it looks fine, but you always have to check the pulse. Always, always, always check pulse. And at which point you just do ACLS and BLS interventions if that winds up being the case. PEA gets grouped in with asystole because compressions and bagging are about all you can do to help them. If you know what the insult was that initially caused this, because there's a handful of them, those interventions can be done. But these are the big ones to really keep them going. And that's all there is to PEA. I mean, really not much else to say on it. Your patient started the shift with rhythm A. Later on, the battery empty alarm sounds and you see rhythm B. What action would be most appropriate? And so this is, again, that question of, is it real or not? Is this emergent or non-emergent? Hopefully you've already notified staff that they need to change the battery ahead of time, but that's not always the case. So they started out in what is AFib with SVR, because this is slow ventricular response, and now it's reading asystole. And you don't know if it's asystole because the battery has been depleted or maybe they're actually in it. So I wouldn't say that this is non-emergent, that the CNA can just change it soon. This is not the kind of thing where the primary nurse can change it the next time they're on rounds. You don't have telemetry, so at this point you need to have that information. Now, is this emergent enough to call an RRT? Probably not, because it's likely to be the battery that's the cause. Are you going to contact the primary nurse immediately and escalate? I think that's very, very reasonable, but if you look at answer C, urgent. You know, the CNA or RN changes that battery immediately because the telemetry is off. I would recommend this as your first action. Contact the CNA, contact the RN, let them know how important this is, that it needs to be changed as soon as possible. If you're unable to get response within a reasonable amount of time, continue to escalate. And so then at that point, I would say E is appropriate as your second step. The telemetry tech notifies you that your patient's battery empty alarm has sounded, creating a systole on the monitor. What first action would be most appropriate? And so you have to decide, is that monitor tech really does not know what your patient's heart rhythm is doing now. Is this a case where it's non-emergent and there's no reason to hurry? Is it urgent, where someone needs to get in there and change it as quickly as possible? Or is it emergent, where you need to call an RRT or something at that level? Well, I'm going to take non-emergent off as a choice because we have asystole. The patient's on a monitor for a reason. We need to be able to see that heart rhythm. So this is a little bit higher end, and so you have to decide, is this an urgent matter or is it just emergent? Well, the monitor tech has likely contacted that primary nurse immediately and is really pushing to escalate if it doesn't get corrected soon. So for you as the nurse at the bedside or the CNA, whoever it may be, this is definitely an urgent matter. It doesn't matter who does it, but that battery needs to be changed as soon as possible. Your patient has just been admitted with rhythm A. Treatments have been initiated. Later, alarms sound, and you see rhythm B. Which action would be most appropriate? And so looking at these two rhythms right away, what can you tell? Well, that this patient here is in a second degree type 1, and so that they're dropping beats, correct? You can see right here where there's no QRSs coming through where they should. And now you're looking at asystole. And without knowing anything else, if your patient goes from a bradycardic rhythm into asystole, that's absolutely emergency, 100%. And so you're going to go ahead and mark those off as not even an option. And you have to say, do you contact primary nurse immediately, or do you just go ahead, call an RRT, and have the ICU nurses be notified of what that rhythm is so that they can escalate accordingly? Delay in care is not an option on the table for something like this. You have to take it very, very seriously. So I'm going to go ahead and say that D is what you need to do. Notify the ICU nurses. This is an RRT. They need to get in there and figure out what's going on. The telemetry tech notifies you that your patient just went into ventricular tachycardia, VTAC, and is now in asystole on the monitor. What first action would be most appropriate? If you've just been notified that your patient had VTAC and now has asystole, that's 100% lethal and is an emergency, hands down. So we're not going to delegate to the CNA. We won't even notify the attending. That would delay care at this juncture. And again, notifying the attending to come evaluate, that is also going to delay care. Now, you could call an RRT on it and have the ICU nurse come, but that again may cause a delay. The true answer to this is you need to get in there. That primary nurse needs to evaluate the patient and initiate ACLS and BLS if there is no pulse, which is likely to be the case. So, as we've gone over many times, get in there as soon as possible, put eyes on the patient, and start care as quickly as you can. If there's no pulse, then you can escalate accordingly.